things that we may not find very interesting, but we got to know. So we start a new chapter, the penultimate chapter of your book, which is healthcare of the community. The last chapter is international health. Now, there are many questions which are asked from these chapters also. Generally, people tend to neglect. They will read the communicable diseases, epidemiology, nutrition, environment, and they will neglect chapters like sociology, healthcare, health communication, international health, from where the questions come and people can easily score. So there is nothing to be in awe of when you see these chapters, and you will keep hearing a word called primary healthcare every time we teach you epidemiology or any other subject. And today you will actually know what exactly we mean by that. Now, the concept of healthcare is predominantly urban oriented. We all know that. It is mostly curative. If I ask 100 of you, what will you become? 99% will say they want to become a clinician. Nobody will say they want to become anatomist or biochemist or pathologist or maybe a public health specialist. But today we lack public health specialty so badly in our community that we are not able to control this pandemic. It is accessible, the curative aspect, the urban oriented aspect, accessible to only a small part of the population, but it has to reach the whole population. If it is health for all, health care for all, we should have the entire community, the entire population having access and affordability towards health. Health care implies much more than medical care. They are not the same word. It's a public right. It's a individual's right. It's a government's responsibility to give you help. In India, it is completely or largely a government function. Unlike some other countries, the health system in India is got a full range of primary health care. As I told you, we will learn more about it in the subsequent slides. Now, this is easy. There are 3 levels, or you can say 3.5 levels of healthcare. The first one is the grassroots level, or the most essential level, that is primary healthcare. Now, this is closer to the people. By people, I mean the urban and the rural people, the disadvantaged, the vulnerable, the people in the village, the illiterate, the ignorant. Okay, they have access to primary health centers and sub-centers. Please remember, do not confuse PHC with primary health care. When you write an answer, when you write primary health care, do not use the abbreviation PHC. PHC is meant for primary health center. So we have primary health centers, sub-centers. We have multi-purpose workers. I mentioned that word in the last class when we talked about the various committees. We have village health guides, VHGs, and we have TBAs, or traditional birth attendants, what we call in Hindi or in colloquial language as Dai. You will see many an old movie where a person is where a lady is being delivered in a hut by a old lady of the community. She is a Dai. Secondary care is intermediate level. The district level, we talked about the Panchayati Raj. We have got 3-tier government, local self-government. The next level is district. And we have the community health centers here, which are known as the CHCs, the community health centers. This is also called as the first referral level. This is the first level of contact or essential health care. This is the first referral level or intermediate level. And then finally, we are in Hyderabad. We have got the bigger hospitals here, the private and the public both. We have got tertiary care, the specialized, super specialized, specific care. We have got the regional or the central apex institutes, NIMS, and various others, okay, which are the government institutes, which are regional institutes, the Sarojini Naidu Institute of Ophthalmology or whatever, the MN Institute of Cancer. So we have got the apex institutes. The referral system, of course, remains a very weak system in our country. It is a two-way exchange program. Remember, there is or there has to be a referral system. You sitting in the primary level will refer patients to secondary care once you do not have the expertise to deal with them. So there is a referral system. It also means that after the patient is cured or after the patient is treated in secondary or tertiary care, he or she is sent back or referred back to the primary care doctor, which never happens. The patient just disappears after taking care or help from the tertiary care institute. So therefore, referral system ideally should be a two-way program. That is what is given in your book, but that thing remains very weak, needless to say. The changing concepts of health we have learned in the second chapter. The comprehensive healthcare was first used by Bohr Committee in 1946. It meant that healthcare should be given from the womb to the tomb, from the birth to death, from the infant or you can say newborn to the elderly or the senior citizen. Provide adequate preventive, promotive, curative services, be as close to beneficiaries. You should remember that a villager does not have the wherewithal, the money, the means to travel to a hospital which is far away, to travel to a healthcare center which is far away. So he requires a healthcare center near him. That is why sub-centers and primary health centers. It requires adequate cooperation between people, service, and profession. You got to cooperate with the people, not always, be against doctors or against healthcare workers and keep complaining. If there is something to help them out with, please help them out with. So there is a coordination and cooperation. It should be available to all, irrespective of ability to pay. The village may have a very rich guy and a very poor guy, but the healthcare should be universal and equitable. Look after the vulnerable and weaker sections and create and maintain a healthy environment in the workplace, at home, and in the community. However, the recommendations of the Bohr Committee, which we read in the last class, which meant comprehensive healthcare besides the other recommendations, has failed over the years. Therefore, the changing concept changed to basic health services in 1965 as developed by the WHO and the UNICEF. You will read about WHO and the UNICEF in the last chapter, which is the chapter on international health. They are potential exam questions. We keep hearing and using the word WHO. We keep hearing and using the word UNICEF. When it comes in the exam, we can't write what they do. What is their function? A network of coordinated and peripheral and intermediate health level units capable of performing effectively a selected group of functions essential for health of an area. The quality or content was unaffected, and this too failed. The basic health services concept also failed. What it meant was that there should be a network of coordinated health units, but then it's the old wine in a new bottle, and it again failed. So therefore, ultimately in 1978, in the conference in Alma-Ata in the erstwhile USSR, a country which no longer exists, there was a declaration which had, in fact, all the points of Sir Joseph Bohr. Imagine Bohr's hard work, sincerity, and the ability to foresee. Now, what was primary healthcare? The words which are written in red needs to be mugged up by you. There is no shortcut. When you are asked in the Bible, what is primary healthcare, you got to just vomit this definition out. Primary healthcare is essential healthcare made universally accessible to individuals and acceptable to them through their full participation and at a cost the community and country can afford. There is nothing to explain here. It should be having 3 A's and 1 C. Accessibility, acceptability, affordability are the 3 A's, and community participation is that 1 C. Please remember this. Primary healthcare, I repeat, is essential healthcare universally accessible to all, acceptable to all, through their full participation. You got to participate in the health activities, in your health. You can't expect the doctor to look after your health. You got to do your exercises, change your lifestyle, have no addictions, and eat healthy. That is your participation, and at a cost the community and country can afford. I hope it is clear to the class that the 3 A's and 1 C needs to be written in the definition for you to define primary health care. This definition will keep haunting you till the time you do or practice medicine. This is valid for all countries and accepted by them for attainment of health for all by 2000. including India. Our country could never achieve health for all by 2000. Certain countries, the advanced countries, achieved, and they are now reaping the benefits. But we then had the Millennium Development Goals and the Sustainable Development Goals. The elements of primary healthcare are 8. This is an exam question, could be a short note, or could be a part of the long question. Education, nutrition, water and sanitation, mother and child health, including family planning, immunization, control of endemic diseases. You can add, NCDs to that, non-communicable diseases, but then that is not given in the book. Appropriate treatment of common diseases and injuries, and provision of essential drugs. Please form your own mnemonic. I have mine. I won't give mine to you. Form your own mnemonic. Write these 8 things in the exam. There are 8 elements of primary health care. I repeat, health education, nutrition, sanitation and water, MCH, mother and child health, family planning, immunization, endemic diseases, appropriate treatment, and of course, how do you treat? With essential drugs and other preventive measures. So therefore, please remember that and mug them up. This is an exam question. Looks like the chapters that you have covered in the book, in the subject community medicine. So 8 elements. And there are 4 principles of primary healthcare. Needless to say, again an exam question. What are the principles of primary healthcare? There are just 4. I'm sure you can remember this. Equitable distribution. I used this word just now. Community participation. I've used this word. Intersectoral coordination. The right hand should know what the left is doing. This department should know what the other department is doing. In our country, they lay a road and then the next day the road is dug up because they want to lay some cable. And you keep cursing. That is because there are 2 different departments working and they don't know what they are doing. There should be proper coordination. Had there been coordination, the road would not have been laid before. It should have been dug up and the cable laid, and after that the road should have been laid. But that never happens. And lastly, appropriate technology. We keep telling you all, keep up with the technology. Now that the technology is developing, there are some new instruments coming, new type of treatment coming. You must keep up with the appropriate technology. An example is the use of artificial intelligence in medicine. Okay, so all of you must be aware that there is a new technology called as artificial intelligence. So please remember ECIA, equitable distribution. The healthcare should be equally available to the rich and the poor, tall and the short, urban or rural, the needy and the vulnerable, or the people who can afford everything. Community participation should be there. There should be people picked up from the community who will help the community, like the village health guides and the DICE. I'll just tell you about them in a while. And intersectoral coordination and appropriate technology. I have explained to you in my own words. I'm sure without reading the book, if you remember the headings, you can just write them. The book gives you a big paragraph underneath each of these headings. You can read them, you can underline the important lines and reproduce about 1 or 2 in the exam. But remember, this comes as a short note. If we see the 4 headings, we know that you know. If you write 3 huge paragraphs and miss out on the 4, you will not get as many marks as a chap who writes all the 4 principles of primary healthcare. So to repeat, there are 8 elements of primary healthcare, which is defined as essential healthcare made universally accessible and acceptable to all through full participation at a cost the community and country can afford. And there are 8 elements and 4 principles of primary healthcare. Remember that. Very, very important. You have to remember them for the exam. Primary healthcare is a different approach, but is it actually different? Previous approaches dealt with taking health services to the doorstep of people. Primary healthcare approach starts with the people themselves. It is health by the people, for the people, of the people. Health by the people, that is placing people's health in people's hands. You will appreciate why I have written it in bold as we progress in this chapter. The finality of this approach is same as the previous ones. That is the final the final aim is the same. Only the approach may be slightly different. But then, have we succeeded? It is for you all to judge. It goes beyond conventional health services and forms a part of the larger concept of human resource development. Pardon my abbreviations, but it forms a larger concept of human resource development. How you handle human resources, how you handle the resources is so important in war and in peace, in health and in health, in sickness and in health. You have to muster your resources in a proper manner. Okay? Health for all, I've already talked about it in the chapter on health. It was a declaration made at Alma Ata. The WHO also accepted the declaration, and all the countries in the world who are a member of WHO, they were signatories to it. They were basically 12 global indicators. India, on the lines of the Alma Ata declaration, formed the national health policy in 1983 to achieve the goal of health for all by 2000. HFA is health for all. The national health policy underwent a change in 2002, and the latest national health policy is 2017, which, if you remember, we discussed in detail in the last class before Niti Aayog. It is actually given in this chapter, but I thought it prudent to be discussed along with the 12 5-year plans, the 5-year plans and the Niti Aayog, because once you understand all three, you will know they are all aiming towards certain indicators to be achieved, including the national health policy. The national strategy for HFA had so many things. They wanted to reduce infant mortality rate, life expectancy at birth, crude death rate, crude birth rate, but then all that is history. Please remember, health for all by 2000 is just for for your knowledge. It should not be asked in the exam because it's history. Therefore, we have something called as National Health Policy 2017, which is now running. HIV/AIDS, I already told you, should be achieved. The target of 90 should be achieved. Eliminate leprosy by 2018. Have we done it? Kala Azar and filariasis by 2017. Eliminate TB by 2025. The WHO has said we should eliminate TB by 2035, but India has got 10 years advance. Reduce your mortality from lifestyle diseases. All these aspects I explained to you as I told you the 3 targets in the last class. In case there is a doubt, you can ask me separately, but let me not waste my time in national health policy all over again. During the national health policy, after 2000, during the health for all, once it was not achieved, the WHO declared the Millennium Development Goals. This is mentioned in a chapter called Sustainable Development Goals in your book. I hope it has been taught. If not, please go through it. It's a short chapter. There is nothing much in it. It can come as a short note. Now, the Millennium Development Goals had 3 goals which related to the health part. And there were 8 of the 18 targets which were health related. And there were 18 of 48 indicators that were indicators of health. Just for your knowledge, remember there is something called as UN Millennium Declaration, which was the precursor of the Millennium Development Goals. The goals were supposed to be achieved between 2000 to 2015, but some countries, they achieved it, and some countries which are developing, which allocate very less money to their health budget, they are yet to achieve that. These are the 8 goals. You can read them in the book, but I'll just quickly go through them. Eradicate extreme poverty and hunger, achieve universal primary education, gender equality, reduce child mortality, maternal health, improve maternal health, combat HIV/AIDS, malaria, and various other diseases. Now we could add COVID to it, to ensure environmental sustainability and to develop a global partnership for development. Well, they are all important words, policy matters, but you just remember that there were 8 goals, of which 3 were health-oriented. MDGs emphasize 3 areas: human resources, infrastructure, and human rights. All that is fine. So since the MDGs, their date expired in 2015, we came across Sustainable Development Goals. And what are the Sustainable Development Goals, or SDGs for short? Proposed set of targets relating to future development. They replaced the MDGs once they expired end of 2015, formally discussed first at the UN Conference on Sustainable Development held in Rio de Janeiro, June 2012. The WHO and the UN always meet before the expiry date of these important goals, and then they formulate the way ahead. So therefore, imagine in 2012, they already discussed and planned the roads towards health for all, or you can say health for universal health for 2030. So sustainable development goals is something which you will also read and try and practice, as you will graduate much before 2030 and you will have to achieve those goals by 2030. Sustainable Development Goals, the UN General Assembly's opening working group on SDGs forwarded a proposal in 2014. There were various negotiations, and by 2015, they had the Sustainable Development Goals in place, and they finally adopted them in September 2015. Just a little bit of history for you to make it a little less monotonous and interesting. Well, the new agenda, that is the Sustainable Development Goals agenda, was transforming our world, the 2030 Agenda for Sustainable Development. That is what was the motto. Now, instead of 8, there were now 17 goals and 169 targets that related towards health. And they included economic, social, and environmental issues, and around the theme, people, planet, prosperity, peace, and partnership. There are 5 P's: people, planet, prosperity, peace, and partnership. It's the same thing what the Millennium Development Goals said: ending poverty and hunger, improving health and education, making cities and villages more sustainable, combating climate change, and protecting oceans and forests, that is the environment. What we have miserably failed in doing so, and that is why we get all these cyclones and tsunamis and earthquakes and floods and various other natural calamities every year all around the world. Even the fires, the California fires, the Australian bushfires, all these are because of climate change, which we have not been able to combat. So therefore, SDGs are aiming to combat climate change, make cities more sustainable, improve health and education, because once you improve education, health improves. Once you improve health, people also go to schools and get educated. They're all, interconnected. So these are the various things that the SDGs aimed to do, or they are aiming to do: end poverty, end hunger, ensure healthy lives, ensure equitable quality education to all, achieve gender equality, ensure water availability and sanitation for all, ensure access to accessible, affordable, renewable, modern energy. We talk about nuclear energy and we talk about wind energy and all these things. Promote sustained and inclusive and sustainable economic growth, build resilient infrastructure, reduce inequality within and among the countries, something which even Gandhiji said, even Ambedkar said, but we never could achieve it. The rich are getting richer in India and the poor are getting poorer. Make cities and human settlements inclusive, safe, resilient, sustainable. Ensure sustainable consumption and production. Everybody should be having access to nutritious diet. But then these are often well said, but they are not achieved. So these are the various things that the Sustainable Development Goals want to achieve. In fact, I have covered the chapter on sustainable goals because in case you remember this much, you will remember what to write in the exam in case Sustainable Development Goals comes as a short note. Well, again, the same thing. We have to combat climate change, have proper ecosystems. We have to ensure justice for all. We have to have a global partnership between countries to ensure that we get Sustainable Development Goals. Well, there is something called as World We Want 2015. This is not from your book. It is just for your general knowledge. The World We Want 2015 is a platform and joint venture currently being used to create a new global development framework to replace the MDGs. Well, the MDGs have already been replaced. it bases its work of the priorities of the people closest to the problems and focuses on local development. So there is something called as World We Want 2015. Just remember that healthcare delivery is something which is the most important part of this chapter. How does health reach you? How does health reach a common Indian citizen? Is something which we all know, but now we have to read it in a bit systematic manner. Now, the model for healthcare delivery includes inputs, healthcare services, healthcare system, and output. Inputs are basically what are the problems? What problem do we have so that we can deal with them? What are the health problems? What are the resources that we have? Okay, healthcare services. What kind of healthcare services do we have in our country? Do we have curative? Do we have preventive? What are the healthcare systems that the various systems that we have? Do we have some indigenous systems? Do we have public systems, private systems? Do we have Ayurveda, Unani? What systems do we have? Do we have a separate system for defense? Do we have a separate medical system for the railways? Well, and finally, what do we achieve from giving the healthcare services through the healthcare system to the people? Do we have proper outputs? Do we have improved or changed health status indicators? How do we measure? I talked about measurement of health way back when we discussed the chapter on health. So now you know why the initial chapters are important, because once you know the concept of health, the concepts of epidemiology and screening, you will be able to appreciate these chapters much better. Well, what are the health status and problems? If I ask you, you will be able to tell me something without even reading the book. Well, what are they? Morbidity and mortality. People are dying. People are getting sick. Demographic conditions. You know, we read about the various demographic ratios, indicators, sex ratio for one, okay? And then dependency ratio, and all these things that we read. So what are the demographic conditions? Are we healthy demographically? What are the environmental indicators? What are the socio-economic factors? Do we have a proper socio-economic distribution, or do we have very, very poor people and people in the lower socio-economic strata much more than the people in the upper socio-economic strata? Cultural background, attitudes, beliefs, practices, they have to be respected because people believe in them. Medical and healthcare services available and other services. So these are what are the inputs we require for health status and problems. Remember, we are talking about inputs. Okay, so what are the problems? Before going into anything, before developing anything, we got to know what are the problems that we have. This is the demographic profile of India. You got to remember certain things here when you come for the clinical postings, because we give you problems on crude birth rate and crude death rate. So the latest statistics show the crude birth rate in India is 20. India has almost 1360 million people today. We have a crude death rate of 6. Okay. And we have a population density of 876 per people per square kilometer. This table is taken from your book. You can just go have a look. The most worrying part is the sex ratio, which is coming down. 898, not even 900 per 1,000 males. In the previous census, this was a little more, 914 or 920 something. Okay? While we are increasing the adult literacy rate, we are decreasing the rural population. People are coming to the cities because there are no or less opportunities in the rural area. So this is something which is taken from your book. You must know what is the demographic profile of India and what are the indicators. This is also in your book. So therefore, the child mortality rate is 39 per 1,000. Infant mortality rate, 34. Still 34 infants out of 1,000 die in our country. Neonatal mortality rate, early neonatal mortality rate, late neonatal mortality rate, post-neonatal mortality rate, perineonatal mortality rate, and stillbirth rate. So we have discussed all this in the chapter on demography, I'm sure, or in the chapter on MCH. You have learned about the maternal mortality ratio and the rate. You've learned about the infant mortality rate. We have only discussed the child and infant mortality indicators here to give you an idea the kind of problems that we have. I told you I'll discuss mortality and morbidity status, and I will discuss the demographic conditions. So that brings us to the health problems in India. What are the health problems? You can rattle it off. communicable diseases, non-communicable diseases, nutritional problems, environmental sanitation problems, medical care problems. There is imbalance. 80% people are urban and 20% people are, 80% of the medical facilities are in urban area, whereas only about 30% people stay in urban area. There is a huge imbalance. People or doctors don't want to go to the villages and serve. Population problems. It has its consequences. We are soon going to surpass China, and we are going to be the most populated country in the world, a dubious distinction. So therefore, there are various health problems which we have to tackle. So what are the resources? Suppose I give you a problem. You need to have resources. You need to have some things to work with. You need to have manpower. You need to have money. So what are the resources in India? The doctor per 10,000 population is 7 doctors per 10,000. Whereas if you see Sri Lanka is almost there, 6.8. The nurses and midwives per 10,000 in India is 17.1 per 10,000. Whereas we come a very, very low line when it comes to beds per 10,000 population as compared to Sri Lanka, which is a smaller and they say a less developed country than ours. But where are we? This makes us stand much lower to Sri Lanka. Today, in the COVID pandemic, we lack beds. That is why today you can see why we lack beds, because we have only 9 beds per 10,000 people in India. When you go for admission to a hospital, people say we have no beds. Okay, that is because we don't have beds. Now, there are certain ideal ratios which have been developed by the WHO. Maybe asked in the exam if you are doing well. Actually, WHO says there should be 1 nurse per 5,000 population. Whereas if you calculate this, we are okay with it, I think. Okay, in India there are 17.1 nurses and midwives per 10,000. The WHO says health workers should be 1 per 5,000 and 1 per 3,000 in tribal or hilly areas. Traditional birth attendants should be 1 per village. Health assistants, we will shortly come to health assistants, is 1 per 30,000 or 1 per 20,000 in hilly and tribal areas. Pharmacists should be 1 per 10,000. Lab technicians should be 1 per 10,000, and ASHA workers should be 1 per 1,000 in the villages. So ASHA workers also, we will read about them. Now, you require manpower. We talked about manpower. We also require money and material. Almost 18% of gross national product is spent on health in developing countries, whereas it is less than 1% and seldom, just a little bit above 2% for countries like India. India spends around only 3%, just imagine. And lastly, the resource that we have is time. We got to have less of administrative delays. We got to have more of days work spent on health work, less on the documentation and the other hierarchy and all these things. Today, if you apply somewhere in the government, that application goes through in days and months. Why is this delay? Because we are used to a work culture like that. So therefore, we are wasting resources. We come to the part which is healthcare services. And we all know this varies from country to country. We will concentrate on our country. The healthcare services should be ideally comprehensive, accessible, acceptable, provide scope for community participation, available at a cost which the country and community can afford. I think now you can remember the primary healthcare definition. This is a very, very important table. Please remember this, because once we go further in this chapter, we will deal with this table. The healthcare systems. We discussed the healthcare services. Actually, what are the qualities of good healthcare services? We discussed the resources and the health problems. Okay. So we have talked about the inputs, where we talked about the health problems and resources. We have talked about the healthcare services. What kind of healthcare services? What are the ideal, aspects of healthcare services? We come to the all-important healthcare system. That chapter is slightly confusing. People who are not attending the class, they may find it difficult to comprehend. People who are attending the class, I keep repeating, go back to your book once your class is over and just have a quick look, and you can see what we have taught. Because I teach exactly from the book to have less confusion among these students. and so that you understand better. As it is, SPM is not a very easy subject to deal with, and people don't develop an interest. Well, primary healthcare consists of the primary health centers and sub-centers at the grassroots level. Then we have the hospitals and health centers at the district level called the community health centers, the rural hospitals, and could be specialist and the teaching hospitals, because you will remember that the government is now transforming district hospitals into teaching centers. Health insurance schemes, the ESI and the CGHS. You have read about the ESI in the chapter on occupational health. And the other agencies I mentioned a wee bit before are the defense and the railways, who have their own health system. The private health sector consists of the general practitioners and the various nursing homes. This is nursing homes. Sorry, this is not the abbreviation that you must use. It is just used by me. NH actually means National Highway. Okay? So private hospital, polyclinics and dispensaries. We have got various general practitioners and clinics. And we have got the India's indigenous system of medicine called as the Ayush now. Ayurved, S is for Siddha, Y is for AY is for Ayush, U is for Unani and Tibbi system, S is for Siddha, H is for homeopathy, and finally we have the unregistered RMPs, unregistered practitioners, and the RMPs, so-called. The fourth healthcare system that we have, which is a big support to the government, is voluntary health agencies. Voluntary health agencies may come as a short note in your exam. And finally, we have the national health programs by the central government, which has been facilitating control and prevention of various diseases. You have read about the national health programs. For example, the vector-borne disease control program, blindness control program, the AIDS control program, and the various others, which may come in the exam in various forms. Primary healthcare in India, this is the heart of the lesson. There is a short history. The rural health scheme, which we read in the last chapter, 1977, placed health in people's hands. They say the people's health is in people's hands. Then we have the Alma Ata Conference in 1978. We have the national health policy coming up. And we have the national population policy in 2002. Finally, we have the National Rural Health Mission and the National Rural Urban Mission. All these led to the various kinds of healthcare systems in India. At the village level, many of us don't come from villages anymore, but your parents and your grandparents once upon a time belonged to villages. Now, what is the health system in the village? There are people who are working day in, day out to improve the health of villagers. And who are they? They are the ASHA workers, they are the Anganwadi workers, and they are the local DAIs. Please remember, when you are asked healthcare at the village level, you have to mention these three functionaries under the various systems, which are the ASHA scheme, the ICDS scheme, which you have already read in the chapter on nutrition, and the DAI scheme. So we will go one by one. ASHA worker. What is the full form of ASHA? Accredited Social Health Activist. Once you start your answer, remember to write the full form of the abbreviation. Many of you write all sorts of funny things. She should be a resident of the village. She should be a woman, irrespective of marital status. Many people write ASHA worker as he. That means they don't concentrate in the class. ASHA worker has to be a female. She is between 25 to 45 years of age. Minimum class 8 pass. Communication and leadership qualities should be there. And she should be from a disadvantaged group. Okay, so that she can relate to those communities in a much better fashion. I already told you the ratio should be one ASHA worker per 1,000 people in a village. So if there are more than 1,000 people in a village, there should be more than one ASHA worker. In tribal or hilly areas, the ASHA workers are one per habitat. The salary of ASHA workers is rupees 7,500 per month in our state. It varies from state to state because state is health is a state function, and there are many states which pay much lower than Telangana. Now, what are the main roles of the ASHA worker? This is an exam question. Exam questions come as ASHA worker or role of ASHA worker. And you must write anything and everything that comes to your mind. You have to just close your eyes and imagine a lady in the village doing health work. What does she do? Nutrition, advice, sanitation, hygiene, overseeing the sanitation of the village, the living conditions, the women who are vulnerable. She prepares them for safe delivery. She tells people to access healthcare facilities, the Anganwadi centers, in the PHCs, okay? And she develops a health plan along with the village panchayat. She escorts the needy to the health facility. There's a serious patient. The ASHA worker escorts the patient, accompanies the patient in an ambulance to the hospital or the primary health center. She looks after the minor ailments. She has got a first aid box where she can give things like ORS, folic acid and iron tablets, the diarrhea kits, the oral pills and chloroquine. Okay, she has got a few drugs in a kit and she can dispense them. She has got the right to dispense them. She is also trained from time to time by the PHC people or the other stakeholders, and she also maintains the various records and passes information to the sub-centers and the PHCs. She also promotes household toilets, something which is there under the Swachh Bharat mission of the present Prime Minister. Remember, ASHA workers have a long role. These are just 10 mentioned in your book, but you can just remember a few and add a line against each. Write about the roles of the ASHA worker. Once your lesson is over, close the chapter and write on a piece of paper what all you remember about the functions. Now, the ASHA worker also has to integrate with the Anganwadi worker, and along with the Anganwadi worker, she organizes health days 1 to 2 times a month. That is not half, that is 1 to 2 times a month. She undergoes training under the Anganwadi workers and the auxiliary nurse midwives. These are the various village level health workers. She undertakes IEC activities, information, education, communication. She also gets drugs issued from the Anganwadi. She helps Anganwadi worker update list of eligible couples and infants. Eligible couple has been taught to you in the chapter of family planning. Target couple and eligible couple. Mobilize pregnant, lactating women and infants for nutritional supplements. The government does a lot. Only thing is that there are a lot of people who are there who are lazy, who are not motivated, and these facilities don't reach the people who they are meant for, like the pregnant, the lactating, the young children, the infants. There is food given from the Anganwadi center. There is a midday meal scheme, but are they successful? There are people who either they make money or they are so demotivated that they do not get these things supplied to the needy. The ASHA worker also has to integrate with the auxiliary nurse midwife in the village. And as I told you, she has to, the auxiliary nurse midwife holds meetings with the ASHA 1 to 2 times a month, gets updation and tells her what all to do, what are the targets. She also trains the ASHA worker, gets information to mobilize people, helps organize health days, helps them take full course of FSFA, that is the pregnant lady or the anemic, motivates antenatal cases to come to sub-center for actual checkups. They get oriented on OCPs or oral contraceptive pills. People who are desirous of family planning, the ASHA worker can give them advice on OCPs because she has been trained and oriented by the ANM. She also learns about the danger signs of pregnancy and labor. This is also something which you have learned in the chapter on maternal and child health, the 14 signs and symptoms or the diagnosis which put a antenatal mother at risk. And of course, she gets compensation for her performance, and in case she has to travel, she gets TADA, traveling allowance and daily allowance. So these are the ASHA workers from our state. See their uniform. If you see some of these people on the roadside, you must appreciate what they are doing. They have got a huge role. They are the people in the village who actually are helping us improve the health status of the villagers. And remember, I again repeat, she is a woman who's selected from the village, from a disadvantaged community, preferably. She should be 8th class pass, about 25 to 45 years of age, and she is given a remuneration of 7,500 per month for her duties. These are the ASHA workers. We are finished with the ASHA workers. We will go to the Anganwadi worker or the Anganwadi teacher. The Telangana state has renamed Anganwadi worker as Anganwadi teacher, and they are under the ICDS scheme. Please remember, they are 1 per 400 to 800 population. There are 7067, about 7,000 ICDS blocks as on date in our country. Now, what are the various things that we look for in an Anganwadi worker, or in short, AWW? She is a part-time worker like the ASHA worker because she has her own family, she has her own work to do. She is paid about 4,500 per month as per the central government scheme. She is now called Anganwadi teacher in Telangana and gets about 10,500 rupees per month. Look at how generous Telangana government has been, and they are paying them more than double of what the center has stated. The Anganwadi worker has an Anganwadi helper, and there are some mini Anganwadis in areas where there are tribals or hilly people staying. They get 6,000 rupees per month from the government. So I am sure you now know that there is a slight difference between ASHA worker and Anganwadi worker in remuneration as well as in the various criteria that goes into selection of the Anganwadi worker or teacher and the ASHA worker. ASHA worker is under the ASHA scheme, whereas Anganwadi worker is under the ICDS scheme. There are two different schemes. And what are the services that the Anganwadi worker provides? Almost the same as the ASHA worker. Health checkups, growth chart maintenance, that is for the infants, immunization, supplementary nutrition, health education, non-formal preschool education, and referral. All these are functions of the Anganwadi worker. Once you have read the ICDS scheme, which is a potential exam question, you will have to write all these things. You remember there's a lovely table given in your book where all these things are formalized, and on the other side they have said who are entitled to these services. Children, adolescent girls, women, pregnant women, lactating women, who? So who are the beneficiaries of the Anganwadi worker? Nursing mothers, pregnant women, other women who are in the reproductive age group, children less than 6 years, and adolescent girls who are less than 18 years of age. Now, Anganwadi worker, like the ASHA worker, is the community's primary link with health and other services, along with the village health guides. Unfortunately, village health guides is no more mentioned in your 25th edition of PAR. I don't know why. This is a photograph of the Anganwadi worker teacher. Just see, she is teaching, giving non-formal education to all these children whose mothers may be working in the fields. They are all under 6. You will find a predominance among girl children, which is very healthy to see. And they are being taught, and she is doing her work. This is the Anganwadi worker undergoing training. These are the Anganwadi workers sitting, and these are the trainers who are training them. Look at the nice Anganwadi center or the training center with so many charts. Okay, Anganwadi Training Center, AWTC. Well, the third very important functionary in the village is the local DAI. She is now called as TBA or Traditional Birth Attendant. Okay, as something which is very, very important. A person who assists a mother during childbirth and who initially acquired her skills by delivering babies herself or through apprenticeship to other traditional birth attendants. You will find that the DAIs in the village, they have learned the skill from their mother or from a female relative. This is something which you know. So therefore, you have to define who is the trained DAI. The scheme was started in 2001-2002. Before that also DAIs existed, but they were not trained. They were actually just handing down the skills from generation to generation. The government thought, let us formalize their training. Let us give them extensive training under the rural health scheme. They are given rupees 300 as stipend, and the aim is to have one DAI per village, or at least one DAI per village. There could be more. They are trained in the PHC, that is primary healthcare center, or they are trained in the sub-center or in the mother and child health center for 2 days every week. Rest of the 4 days or 5 days, she has to accompany the health worker female, the auxiliary nurse midwife, or the health assistant female, and in the end of the training, the DAI gets a delivery kit and a successful completion certificate that she has undergone. Now, the DAI is there to improve elementary knowledge of mother and child health. She can advise on sterilization and propagation of small worker, ask for the village health guide or the traditional DAI and the Anganwadi. Visit the Anganwadi. Village health guide scheme was started on Gandhiji's birthday in 1977, and except the 3 southern states, Arunachal and J&K, all the other villages had the village health guide scheme. The village health guide was basically a resident and basically a woman selected from the community. She had the ability to read and write. The basic education was up to class 6, and they should be acceptable to all sections, and preferably 2 to 3 hours of voluntary work was required. They were also trained in the PHCs, given a very, very measly honorarium of 50 rupees per month. Today, 50 rupees fetches you nothing. And they were given rupees 600 per year worth drugs. These are old, remunerations. I don't know about the recent ones because your book doesn't actually give something on village health guides. So in case you forget to write this in the exam, I am sure no marks should be deducted. But you must not forget to write about the ASHA workers, the Anganwadi workers, and the traditional birth attendants. The village health guide aided in first aid. He knew how to give simple treatment for simple ailments like cough, cold, fever, and he also gave advice, or she gave advice on the mother and child health, family planning. They were adept in giving health education and also looking after the sanitation of the village. So after the village, the next level is the sub-center. Though the sub-center is located in the village, but the sub-center is the next level that we come to. We are discussing the various levels at the primary healthcare level. We have not even gone to the secondary healthcare. We are still in primary healthcare level. Please remember that. Secondary healthcare and the tertiary care and the other systems we will be only able to discuss in the next class. Now, this is an exam question, sub-centers. It is 1 per 5,000 population. We will ask you, how many people do the sub-center represent? So 5,000. Don't say that you don't know, or 10,000, 20,000. That shows that you don't know. And 1 in 3,000 for hilly and tribal and backward areas. Okay, there are today 25,000 plus primary health centers in our country. And each primary health center caters for 30,000 population. Therefore, 30 divided by 5, we have got 6 sub-centers under each primary healthcare center. It provides an interface with the community at the grassroots level, provides all primary healthcare services, and it is staffed with 1 lady health visitor. LHV is lady health visitor, 1 health assistant male, so lady and a male. And these are the people at the PHC who supervise. So the lady health visitor and the health assistant male who are in the PHC They visit the sub-centers one by one and they supervise. Okay. Now, who are the people who are working? I'll just come to that. What are the services which are given by sub-center? It's a repeat. We have discussed the ASHA worker, the Anganwadi worker. So this is something which you must be knowing by now. Immunization, antenatal care, natal care, postnatal care, prevention of malnutrition among children, especially common childhood diseases, family planning services and counseling, elementary drugs, implementation of national health programs, and training. They train the Anganwadi workers, the ASHA workers from time to time. We or doctors also require training. That's why we attend seminars and continuing medical education, that is CMEs. We attend them because we need to be trained by and by. What we have learned in our MBBS in the 80s and 90s, we have forgotten. So we need to be updated. We need to be trained. Similarly, the sub-center is a training center for the grassroots level healthcare workers. Now, friends, please remember this IPHS. IPHS is Indian Public Health Standards. These are standards which were revised in 2012 and they are in vogue. They are being followed. Okay, the IPHS standards are very, very important for sub-centers and primary health care centers or primary health centers, sorry. They are also important for the community health centers because all three have got IPHS standards. That means they are standards which are set by the government which they should be achieving. Now, just a couple of minutes more. There are two types of services given in the sub-centers, okay? Essential and desirable. It is essential that you read the chapter. It is desirable that you read something extra, okay? So I hope you know what is the subtle difference between essential and desirable. And what are the workers which are, there in the sub-center? We have a health worker female or an auxiliary nurse midwife. I'll repeat this again. We have a health worker male or a multi-purpose worker male. So a male worker and a female worker. We have a voluntary worker to assist the A&M, preferably the traditional birth attendant. She's also a part of the sub-center, so optional. And we have got a total of 2 to 3 workers. Of course, the recommendation is that we get 2 health workers female, but whether that is possible or not is difficult to say. Now, there are 2 types of sub-centers, type A and type B. Type A has got all the facilities except the facilities for conducting deliveries. Please remember, type A, no deliveries. Why? Because there are space and infrastructure constraints. The nearby facilities, that is, it may be located near a PHC. So why add on to that? We have a big hospital nearby, the sub-center. So therefore, it is a type A sub-center. The government doesn't want to spend on the infrastructure and make it a delivery center. Okay? And of course, it is a low case load. In that area, less people come. So type A. Type A can always be upgraded to type B, where deliveries are conducted depending on the load. The A&Ms are trained. Okay, the auxiliary nurse midwives are trained and they are called as SBA, skilled birth attendants, and conduct deliveries. All other recommended services of the sub-center, as I mentioned, must be provided in type A. Immunization to antenatal care to family planning, the implementation of national health programs, training. Okay, so all other programs are carried out except for the deliveries. Needless to say, type B is also called as MCH sub-center. And here we conduct all types of, we conduct the normal vaginal deliveries and they are type B. A&Ms and trained SBA, they conduct the normal deliveries. There is space and infrastructure available, which was not available in the type A, and it is centrally located. Nearby delivery facilities are inadequate. That's why the government wants to upgrade it. And has been restored. I hope you can hear me. Just the last minute. And we have a newborn baby care corner in the sub-center type B, where the newborn babies are kept for a while. The sub-centers have 2 beds in case there are 20 deliveries per month, which is the statistics of previous months will tell you. In case there are more than 20 deliveries, it's a highly busy center. We have got 4 beds, and the government gives you extra equipment, drugs, and supplies. So, ladies and gentlemen, we have talked about the definition of primary healthcare, starting with a little bit of history. We have gone on to define the elements and the principles. We have talked about how the healthcare is delivered in India as a part of that. We are now discussing the healthcare system. In the healthcare system, we have got the primary health centers, the sub-centers, the village level grassroots workers, and the various other things on the hierarchy. Now, in the village, there are very, very important workers who are actually doing yeoman service to the community. They are the ASHA workers, the Anganwadi workers, and the traditional dais. You may add the village health guides. Then we came down to the sub-centers, and we discussed about the 2 types of sub-centers, type A and type B. Type A doesn't conduct deliveries. Type B conducts deliveries. Okay, and at the site of service delivery, the sub-centers are located in the villages. They go from house to house, the workers, and take down the statistics. They do house-to-house surveys. There are meetings and events, and that is called as outreach activities. The facility provided by the sub-centers are 6 hours of OPD, 6 days a week. When 2 ANMs are available, I talked about only one. One is for OPD and one is for going from house to house. Okay, these are the various services of the sub-center. They are the same things being repeated, the same functions of the ASHA worker and the Anganwadi worker. I don't want to confuse you. As it is, 1 hour of class is enough. And you must note down these services or the things in capital from your book and just write them down in the exam, because there won't be time to elaborate on them. Disease surveillance, national health programs, promotion of Ayush, vital events recording, field visits, sanitation, water, mother and child health is the most important. Looking after the mother and the child is the most important function of the sub-center. These are the various types of manpower which are essential and desirable. I told you about 1 ANM and 1 health worker male and 1 traditional dai who assists, and of course a Safai Karmachari who's part-time. Whereas in the type B, we have got 2 ANMs, and that is the only difference. In the next class, we will talk about the primary health center. Very, very important, a very, very oft repeated word that you may have heard, and we will discuss in detail about the other types of health services available in the country. Thank you all for a patient hearing, and I think I have eaten into the next class 1 minute, so please pardon me. Thanks a lot, and all the best.